SolrX Incorporation and its review programs are neither related or endorsed by Pharmacy Examination Board of Canada, which is also known as a PEBC. SolrX Incorporation does not provide any certifications. PEBC is a trademark of Pharmacy Examining Board of Canada and is not related to SolrX Incorporation.
So I think some people are going to trickle in, but just let's get started. So firstly, thank you guys for coming today to this wonderful review that Farah has offered to conduct. And any questions you might have, it's great to see people are participating, sharing their experiences. And that's what our goal is, to create this wonderful group where people they feel free to share ideas, questions, anything that's not clear, concepts. We're here to help out, and we make sure that you guys have mentors. All of us have been through this exam. All of us have had various different experiences or different strategies that have helped us to clear the exams. So that's what we're here for. So again, feel free to participate. I'll hand it over to Farah, who's had a wonderful experience with academia. I can see a lot of you already know her, so she does not need a lot of introduction at all. So Farah, please, the floor is all yours, and take it over.
Thank you. Okay, so welcome, dear students. We'll be doing a brief diabetes review to look at how we approach patients who are uncontrolled after using metformin. So one of the biggest challenges, even in the last 5 to 10 years, was somebody's diagnosed with diabetes. They start on metformin, which is, your gold standard drug. But after metformin, what do you do? What do you do? What does the patient take? And there's been lots of variations of the guidelines and changes in recommendations. And we'll talk about the unique properties of the medications. But before we get into that, you really have to understand what is diabetes. It's funny, and you guys have heard me say all these things before, but when you ask a patient, you know what diabetes is? Do you know what hypertension is? They'll say, yes, I know. Yes, I know. But a lot of the times, people actually don't know the depth. If you don't understand the root, you will never be able to understand how to solve complex issues. So let's take a brief look at this picture over here. In a healthy person, they eat food, okay? Food goes into the tummy. The tummy breaks down the food into sugar, okay? Sugar is energy. Sugar is used by your muscles, by your organs for energy to function. But how does glucose end up in your organs? How does glucose leave the bloodstream? Insulin. So your pancreas releases insulin. Think of insulin as the driver. As it's like your Uber driver, from McDonald's. I had McDonald's today. Don't judge me, from Uber. It takes you from McDonald's. It's like your Uber driver. Your insulin takes your McDonald's to your house. In this case, it takes the sugar from the bloodstream into the organ for energy. So that's an unhealthy person. So I had a burger today. My insulin, helped me to take all the sugar from my hamburger into my muscles for energy. Now, if you have type 1 diabetes, and this is usually diagnosed very young, they don't have any insulin. So what does that mean? So take a second, don't read the slide, think about it, because the goal is here to really understand. If somebody doesn't have insulin, what happens? In one line, what happens if there's no insulin? Anybody? You have to participate. What happens if there's no insulin? No energy? Okay, tell me more. No energy, sugar stays in the blood. Exactly. So you're very good. So the sugar will stay in the blood. The blood sugars will spike, spike, spike. and the organs will start to die because the organs will be hungry. Exactly. Very, very good. So the sugar will not get to where it needs to get. Very good. So people with type 1 diabetes have zero insulin. So they need to be on insulin injections for their whole life. For their whole life. If somebody has type 1 diabetes, can we give them metformin or no? If somebody has type 1 diabetes, why not? Why can't you give them metformin? Why? Why? You need external insulin. Exactly. Very, very good. Very good. So the oral medications used in diabetes, your metformin, your gliclazide, your glyburide, they help your body to utilize its insulin. So that leads me into type 2 diabetes. So let's look at type 2 diabetes. You eat food, the food breaks down into glucose. But this is where it gets funny. We have something called insulin resistance. So what does insulin resistance mean? In insulin resistance, your body is making insulin, but I am not able to use it. You know what you can think of it is? It's like, remember we were talking about our Uber driver, our insulin? Think of the car having a flat tire, okay? So you have a car to take the food from the restaurant, but the tire is flat. Think of it that way. Exactly. So insulin is there, but your body can't use it. It's like a car with a flat tire. You can't drive. The oral medications help the body to utilize its insulin. Very good, to stimulate the process. However, as diabetes progresses, studies show that the body will start to make less and less insulin over time. So over time, especially in uncontrolled situations, they may end up requiring 24/7 insulin. So very good. Does this make sense? On your exam, they can trick you. You can get a patient they can say, type 1 diabetes, and they'll say, okay, can we give them metformin? That can be your question. But if you understand, okay, well, in type 1, no insulin, we don't use oral medication. Does that make sense? Is that clear? Yeah? So now we understand the root of a healthy versus type 1 versus type 2. Very good. Now we go to the next slide. Next, what are the targets? So in the past, the guidelines used to say, okay, your A1C should be less than 7 or less than or equal to 7. What is your A1C? Your A1C is a measure done through your blood work of the average of your sugar readings over the last 3 months. Okay, so you get an average reading of your sugars over the last 3 months. With A1C, can you see when if a patient has hyperglycemia in the morning or at night? Can you see trends with A1C? Or is A1C just a number? Looking at your comments. A1C, very good. It's just a number. So it'll just give you a general average. It will not say, okay, someone's sugar was high in the morning, someone's sugar was low, or it will just say, okay, this is the average over the last 3 months. Up until recently, the guidelines said everybody's A1C should be less than 7. Then in the last few years, they made changes. And they said, oh, wait, there are exceptions. And this is something you have to understand. And this is for your exam going into tips. These are the gray areas. Remember, you guys know me first talking about the gray situations where there's no right or wrong. You cannot read it in a book. If you have a patient who has dementia, Alzheimer's disease, very severe, are you really going to have them have a very tight A1C of less than 7? Are you going to put them on multiple medications that'll cause side effects? Put them at risk of hypoglycemia? No. In those cases, we'll say, you know what? A higher A1C is okay. That is something that can also appear on your exam. Exactly, because risk of falls in elderly. So they can very well tell you on your exam. A nurse practitioner calls you and says they have a patient with Alzheimer's disease and their sugars, their A1C is 8 and they're already on 2 oral medications. Should we add on another one? No. You should be okay with the higher A1C. And there's no exact number in these situations. So some students will say, okay, Farah, well, what's the exact number? There's no exact number. You just know that if somebody has some kind of impairment, cognitive impairment, lives on their own with no support, barrier to language, barrier to understanding, we are okay with the higher A1C. For the average healthy person who understands how to take medication, knows what to do, usually their target is less than or equal to 7 of A1C. But let's say you have a patient who is getting complications from diabetes, like trouble with vision, okay? They're losing their vision from uncontrolled diabetes. They're getting, pins and needles sensations under their feet. I still don't know, I'll share with, I think I told you guys this in the past. I remember I was a student, okay, in the pharmacy. I was like second year pharmacy school. And they said, okay, Farah, you have to do a diabetes clinic. And I said, absolutely, I'm happy, book people in. And I said, do you want me to do a medication review? And they said, no. They said, you have to do a foot care clinic. And I was like, what? So I remember I had like 10 people come in. It was like spread out by half an hour. They took their feet out, they took their socks off, and then they gave me these like pricks or whatever needles, and then I had to poke their feet to see where they don't feel anything, right? Neuropathy, diabetic neuropathy. Because what happens with neuropathy is you lose sensation in the bottom of your feet. So for some people, maybe something will get into their feet and they won't even know because they'll have no sensation, and that can develop into an infection. But anyway, so I'll never forget that. I was like, it was a good experience, but it was like really traumatizing. You guys are not even laughing or saying anything, but it was pretty traumatizing for me. But anyways, that's neuropathy. But if somebody has that and has, retinopathy, neuropathy, then we'll say, you know what? Oh, you remember this? Yeah, tight. Yeah. Then we'll have tighter control. So less than or equal to 6.5. One more thing I will mention. Some people get patients and doctors will get very, very stressed about low sugar. High sugars. Let's get their sugars down, get their sugars down. But hypoglycemia is actually more harmful than hyperglycemia. So we have to be mindful to find the balance. Anyways, do you see how it's very much about looking at the patient? There's no number where you have to memorize here. But very good. Okay, now let's talk about the popular stuff. Your GLPs, your GIPs, your Ozempics, and what is all that about? So let's go back to our example of eating food, okay? Let's say you ate an apple, which I definitely did not eat today, but that's okay. Let's say you eat an apple. When you eat food, you have these hormones that are released. You have your GLP-1s. Let me draw over here. GLP-1s and then your GIPs. These are your incretin hormones. So your glucagon-like peptide and then your glucose-dependent insulinotropic polypeptide. You don't have to know the exact acronyms. But these incretins are released once you eat food, okay? And then you'll see all of these little circles, which are your incretins. These are your GLPs and these are your GIPs. So now, once these are released, they bind something called DPP4. Okay? Once they bind to DPP4, I'm not sure if you can see the full screen over here. Once they bind to the dipeptyl peptidase 4, these incretins get broken down. When you take a DPP4 inhibitor, so when you look at the very, very bottom, your incretin hormones stay longer. And why do we want them to stay longer? Why do we want your GLPs and your GIPs to stay longer in the blood? Does anybody know? What is the benefit of these GLPs and GIPs in the body? Feeling of fullness, and what else? More insulin is released. You're using your body's insulin, exactly. So if you eat an apple, you have these hormones come out. You want the hormones to stick around. You want them to cause more insulin to come out. You want them to lower the blood sugar. You want the organs to have energy. But then we have this DPP4 that breaks it down fast. And that's why you will have drugs called DPP4 inhibitors that'll prevent their breakdown. Does this make sense? A lot of people ask me, they get confused with the DPPs, the GLPs, and you have to have a high level of understanding. So on this next slide, we'll come back to this. Let me clear my funky writing over here. So these are your basic treatment options. Your GLP-1s, they increase insulin. I'll write that as I. These increase insulin. This one blocks the breakdown of these agents, and then we'll talk about this a little bit later. Should I go over that again? It's a little bit confusing. I always notice this one is a little confusing. Does that make sense? If I say GLP receptors, GLPs and GIPs, you should know what that means. And if you're okay, let me know. I'll wait. No comment? Repeat. Okay. Let's do it one more time. When you eat food, okay? When you eat food, you have hormones that are released. These hormones are called the incretin hormones. The incretin hormones are your GLPs and your GIPs, GLPs and your GIPs. So glucagon-like peptide, for example. So these hormones allow for the body to utilize its insulin. They increase the availability of insulin. And they do other things like help you feel full and all of that. But in the context of diabetes, they increase insulin. But the problem is you have an enzyme in your body. The enzyme is called DPP4. So you can see it looks kind of like, like that Pac-Man? You see the little orange, like the Pac-Man, the DPP4. So you'll see the DPP4 breaks down your GLPs, your incretin hormones. And it naturally does that. All our bodies have this DPP4 enzyme. Because think about it, without DPP4, you will have so much insulin being released constantly, right? Your incretin hormones won't stop. You'll constantly have an influx of incretin hormones and insulin, which will cause hypoglycemia. So dear students, it's all about a balance, right? So in the healthy body, you will have this DPP4 to break down the incretins at the right time. But when you have somebody with diabetes, we're not getting enough insulin secretion as it is. So we want more incretins. We want more GLP. We want more GIP. And that's why we make drugs that block DPP4 to prolong the life of the GLPs and GIPs. So very good. GLP, and so now when we're looking at the treatments, your GLP agonist, your GIP agonist increase the activity of the incretin hormones. And then your DPP4 inhibitors prevent their breakdown. Does that make sense? And very well said online. Does that make sense? Okay, very good. So you have to understand. So now you look, you see your GLPs, your agonist, your GIP agonist. They allow for the incretin hormones to work to have insulin. And then your DPP4 inhibitors, it's like your Pac-Man, right? You want to block the breakdown of your incretins. And then I brought up here your SGLT2s, which we'll talk about in a second, which is a little bit different. But I brought it up because they're very hot in the guidelines and very much discussed. So what about SGLT2 inhibitors? They don't work like your GIPs and your GLPs. These ones work to, to say it in simple terms, urinate out the glucose. So you're blocking reabsorption of glucose. Because you can see here, you have this transporter here, your SGLT2 transporter, okay? This SGLT2 transporter takes the glucose, which is green, back into the blood for reabsorption. But your SGLT2 inhibitor blocks this process so that you urinate out glucose. So just think of SGLT2 inhibitors, you're urinating out glucose. And the reason why I brought up this drug class is because it's heavily discussed in the guidelines. So for the purposes of your exam, you don't have to know the details of the pharmacology, but to this extent, you have to have a high-level understanding. Otherwise, you will get confused in how to initiate therapy. So now we know all the different agents that are very important. I will not talk about, your pioglitazone, rosiglitazone, and gliclazide, glyburide, because we don't really initiate those anymore. Your thiazolidinediones, your rosiglitazone, pioglitazone, we never start them. I remember, if you guys remember me saying in the past, I have never found one reason to start those. They can cause bladder cancer and a lot of issues. Your sulfonylureas like gliclazide, glyburide, they cause significant hypoglycemia. They have no mortality benefits. So there's no reason to start them. These drugs discussed here, except DPP4s, the only reason I talked about DPP4s is because they're kind of related to the GLPs, but your GLPs and your SGLT2 inhibitors have shown significant mortality benefits in people with a cardiac history and a kidney history. So the guideline says, okay, after you start somebody with metformin, we need to pick an add-on drug that has cardio-renal benefit, so heart benefit and kidney benefit. And these are the drug classes that are your go-tos. And we're going to talk about them now at a high level. So going back to what I just said, why am I so focused on just a few treatment options? So if we look over here at starting metformin, If they haven't reached their target, this is what the guidelines say, what do you do? And this is what the PBC says, what do you do? What do we do after metformin? Okay, now this gets a little bit funky, so bear with me, okay? We'll start at the very top and work our way down, and I'll do it 10 times if I have to, so don't worry. The first thing I ask, does the patient have a cardiac history? ASCVD is a fancy word called atherosclerotic cardiovascular disease. All that means is heart attack, okay? And it's just a fancy word for myocardial infarction, stroke, any clot-related disease. So do they have a cardiac history of a heart attack? Or do they have chronic kidney disease? Or heart failure? Or, this one is relatively new. Is the patient over 60 and has at least two risk factors? Those risk factors could be high blood pressure, high cholesterol, smoking, and central obesity, so like weight on the belly area. Okay? So over 60 with at least two risk factors. Like I said, what are the risk factors? Hypertension, high cholesterol, smoking, and obesity in the tummy. So now I'm going to say all of it one more time because I want you to remember this when you leave today. If a patient has a history of a heart attack or heart failure or kidney disease, regardless of their age, or they're over 60 with two or more cardiac risk factors, we have to pick a medication that has a cardio-renal benefit, meaning it protects the heart and the kidney. Does that make sense up until what I just said? Yeah? Are you with me? Okay. I see one person, two, three. Okay, there's more people, so I feel a little better. I'm like, is it just me here? Okay, good. Okay. But now here's the thing. How do you pick a drug? The guidelines made the table very, very fancy. So I'm just going to give you the summary. Don't look at anything. You see how it's like green here and then there's purple. Purple, ignore blue. We're just going to look at everything green. And I'll make it a little easy for you. All you have to know is that if somebody has heart failure or kidney disease, there's more evidence to do an SGLT2 inhibitor. So CKD, heart failure, the add-on is an SGLT2 inhibitor. If they're over 60 with two cardiac risk factors, give them the GLP. If they have a ASCVD, so a clot history like a heart attack, you can do either one. So let me write that for you in one line. Okay. So first, so if they had cardiovascular disease, so like a stroke or a heart attack, if they had kidney disease, if they had heart failure, or if they were, over 60, blah, blah, blah. Plus, okay, move this here, plus two risk factors. Okay, so I'm gonna put an arrow, 2, 3, 4. Let me change a color here. Let's do blue. So like I said a second ago, if they have chronic kidney disease, The agent we add is an SGLT2 inhibitor. If they have a history of heart failure, SGLT2 inhibitor. If they're over 60 with those two risk factors, we will add on GLP, receptor agonist. If they have a history of a heart attack, for example, you have a choice, and we'll talk about that. You can do GLP, receptor agonist, or GLT2. That was supposed to be a slash, but SGLT2 inhibitor. That's it. That's it. Now you know. Does that make sense? So now when you look at a case, if somebody was on metformin, okay, I'll ask you guys this based on what I just wrote. Somebody is 50 years of age. Okay, your patient is 50 years of age. They have diabetes. They're on metformin. Their A1C is still high. The nurse practitioner wants to add on a medication. They had a heart attack a year ago. And they're 50 years of age and they had a heart attack a year ago. What do you add? And if you don't know, say, Farah, I don't know, because I'm okay with that. You know that. GLP or SGLT2. Exactly. What if, very good. What if the patient was, let's say the patient was 80 years of age and had chronic kidney disease? What do you add? SGLT2. That's it. You did it. Exactly. And then we'll talk in a second, we'll talk about the differences between the GLPs and the SGLT2s, and I'll give you my 2 cents, but that's it. Isn't that wild? That's all you need. The way the guidelines write it, it's just ridiculous. They try to show you the guidelines and yada, yada, yada. It's too much, the details of the studies. On the right-hand side over here, so you'll see, very good, by the way, good job. The right-hand side over here, all this says, which is unlikely to appear, basically is the patient doesn't meet any of those criteria, doesn't meet the CVD, doesn't meet the CKD, doesn't meet the heart failure or anything, doesn't meet any of that, but needs medication. So in that case, it's risk versus benefit and side effects. Don't worry about that. But do you notice here that I didn't talk about DPP4? Remember earlier I was saying, okay, well, we'll touch on DPP4. DPP4 inhibitors don't have that cardiovascular mortality benefit. Okay, they don't. It's just your GLPs and your SGLT2s. DPPs, none of them do. Neither do your sulfonylureas, even though sulfonylureas have been used for a very, very long time. Does this make sense now? Now, do you feel like, okay, if somebody is on metformin and you need to do something and give them a medication, now do you know what you need to do? And if not, you can say no. You can say Farah, no. And that's okay, and I'll explain it again. I'm easy, so you know that. Yeah? Okay. And if a person, remember again, if a person doesn't meet any of this, like they're, no cardiac, no history of anything, then we'll go through each drug and say, okay, well, do you want an injection? Do you want an oral drug? Is cost an issue? Like, then you can do anything you want, essentially. Okay, very good. I feel like I'm more excited than you guys are, but that's okay. Because I feel a little bit excited about this, that, we're cracking this. It's good. because this is a very hot topic, especially these days with Ozempic and diabetes. And, you know, I do some shifts at Costco pharmacy. You guys should see, we have like a massive fridge. It's like I'm 5'1", it's taller than me. All Ozempic, which is your GLPs. It's all Ozempic. What if the patient is over 60? Which two risk factors, but also has the very good question. That's a very good question. Okay, so the question is, if somebody is over 60 and has two risk factors, but also has CKD, which one do we give? So why don't we let me write out the thought process. So if they're over 60 with the two risk factors versus if they have CKD. So if they have CKD, we said we would do SGLT2. Okay, if they're 60, another color over here. If they're over 60 with two risk factors, we'll do GLP receptor agonist. And then in your question is, which one do we give? So in this case, there's no like direct guidelines towards one or the other. So if I had to pick, this is how I would break it down in my head. If somebody has chronic kidney disease, they're already at high risk of kidney-related complications. So I would pick the drug that is nephroprotective or protective for the kidney. So in this case, I would do the SGLT2. Do you see what I'm saying? Because yes, somebody's over 60, they have two risk factors like high cholesterol, high blood pressure, okay, fine, that is important. But if somebody has kidneys that are not working, they're not doing well, I would pick the drug to help the more severe situation. Does that make sense? It's not black and white, but it's a very good question. Do you see how I rationalize it? Yeah? Okay. Do you see how I'm like, okay, which one is more urgent, the situation? The CKD is more of the urgent situation. What will we give in addition to metformin if none of these situations? Very good question. So in that case, you can give anything and everything. So what I would do is, can I repeat once more? Yeah, like my answer to this, and then I'll answer the next one. Absolutely. So, if we're saying, okay, well, the patient is over 60 with two risk factors like high blood pressure, high cholesterol, and they also have kidney disease, what do you do? Do you do the GLP or do you do the SGLT2 inhibitor? I would say, okay, well, what's more important right now? We need to give the patient the medication that'll protect the kidney. Because in this case, the SGLT2 inhibitor has some kidney protection. That's why it's meant to be used in patients with chronic kidney disease. So that's why I would say, okay, CKD is more urgent. Let's protect the kidney. Make sense? Always go for the more urgent situation, or maybe not the word urgent, but more severe situation. And then the next question, what will we give in addition to metformin if none of these situations? Anything. So in that case, you talk to the patient, what do they want? Do they care about weight loss versus weight gain medications? Do they care about oral versus injectables? Do they want insulin? Are they pregnant? But on your exam, in this case, it would probably be one of these, or it would be related to weight, like the drugs that cause weight loss, which we know what they are, your GLPs, and we'll cover it more in the course, but your sulfonylureas cause weight gain, your thiazolidinediones cause weight gain, and things like that. But usually it'd be one of these, which is what the guidelines focus on. By the way, just so it came to me, do you guys know what to give what is safe in pregnancy for treatment? So if somebody becomes pregnant, what's the safest? Anybody know? And if you don't know, say Farah, I don't know, because that's okay, I'll tell you. So insulin is the best. But if they don't want to inject themselves, metformin. So insulin is number one, but if they don't want to inject themselves, then metformin. Well, what if, let's say metformin's not available? What's the next option? Glyburide. Very good. Very, very good. Glyburide, exactly. You guys are killing it. I love it. Very good. Very, very good. Very, very good. Let me clear all this. Ooh. So this is just another way of illustrating kind of what we talked about. So essentially, I just want to show you why insulin is preferred over metformin in pregnant women. That's a good question. I don't know why. I would assume it's because I don't know. I don't know why it's preferred. I think maybe it's just known to be safer. Okay, let's take a look over here. This is just a summary. So look at the top. You start the patient on metformin, and then we have to, after that, add on the medication. Look in the middle. You'll see people with high cardiovascular risk, meaning either the over 60 with 2 risk factors or history of stroke or heart attack, then heart failure, then CKD. So those are really the heavy breakdowns. And then if there are no preferences for, like, there's no heart failure, no cardiac history, then you can give anything, side effect profile. Just high level. When it comes to renal dysfunction and diabetes medication, now you don't have to memorize very specifically, but there's a few things I really want to draw your attention to. Here, let me get my pen. So I want to look at here. Let's look at your GIPs and your GLPs. Actually, before I get into that, I want to mention something. So tirzepatide, I don't know how you even pronounce it. This is your Mounjaro. It's called Mounjaro. This is one that we use for weight loss. So this drug is dual. It works on your GLP and your GIP. This one has not been studied enough to have mortality benefit. So if I go back a few slides, just to highly mention this. See here, we really focused on your GLPs and then your SGLT2 inhibitors. Tirzepatide has GLP-like action, but also has GIP action. It's another incretin hormone. Anyways, all you have to know is that this drug, which is very well now used for weight loss, doesn't have enough mortality benefits and cardiovascular benefits yet. Well, not studied enough yet. So we wouldn't start this right away. And thank you to Ara for your explanation. Thank you. Okay, let's go back. Perfect. Okay, back here, you don't have to memorize all of the doses for kidney dysfunction, but what I want to point out, let's look here. Your GLPs. And you can see here in the kidney function, you can see high eGFR, and then as you go down, lower kidney function. you can see till the very bottom, your GLPs are safe to use. Okay, so you can say that in kidney dysfunction, your GLP-1s are okay. I wanted to compare this to your SGLT2 inhibitors. Look at this, is interesting. If somebody has a GFR here, 25 or 20 or 15, if they were already taking the SGLs, they can continue, but we don't start it. Isn't that interesting? So I just want you to be mindful of that. Just know at the back of your mind that GLPs can be initiated in severe renal dysfunction. But your SGLT2 inhibitors, you should not start them, so you do not initiate in severe renal dysfunction. But if somebody's on it, you can continue. And the studies show that, let's say, okay, a patient is on dapagliflozin, okay? And they've been using dapagliflozin for years, and now their kidneys are worsening, and now their GFR is around here. Okay, so we can continue the dapagliflozin. But the studies show that dapagliflozin may not be as good for lowering sugar in severe kidney dysfunction, but it'll still provide those cardiac, renal, mortality benefits. So it'll have those benefits, cardiorenal benefits, but its ability to lower sugar won't be as good in this case. Does that make sense? And another question is, GLP medication contraindicated if the patient's mother has thyroid cancer? Yes. Yes, because of its history of medullary thyroid cancer. And now to answer the question, but will we give it? Okay, I'll explain again. If somebody is on dapagliflozin and their kidneys are working, and over time their kidneys deteriorate, we can continue the dapagliflozin. But if you have a patient who was never on dapagliflozin, and now their kidneys are like here, GFR of 20, I wouldn't start it. Because here you do not initiate, but if they're on it, you can continue. So that's kind of what I wanted to bring to your attention. With the SGLT2 inhibitors, in severe kidney dysfunction, as the GFR goes down, we don't start it in severe kidney dysfunction, but we can continue it. Versus your GLPs or GIPs, you can start it at any time. Okay? And I want you to know which medication, and it's already here, but which medication is safe in kidney dysfunction all throughout? Linagliptin. Where did that go? The pink. Linagliptin is safe all throughout. So remember, linagliptin is safe in all throughout, whether good or bad kidneys, you can use linagliptin. So when in doubt, use linagliptin. Does that make sense? So if somebody has MACE, which one to select? So you mean major adverse cardiac event? We wouldn't do DPP4. DPP4s do not have the significant mortality benefits. It would be your SGLs or your GLPs. Okay, now I'm going to erase all of this. And then I just wanted to show you at a high level what the guidelines would said about the drugs. Not all the drugs, but about your incretin medications. So your GLPs and then your SGLT2s. Because you know what? I was thinking, you know how I said if somebody has ASCVD, so if atherosclerotic cardiovascular disease, so they have if they have here, if they have a history of a heart attack, stroke, you can do your GLP or your SGLT2 inhibitor. In my mind, the first thing that comes to my mind is, okay, well, what if I'm stuck between both options? Which one do I give the patient, right? Do I do GLPs or do I do SGLT2 inhibitor? So when I was looking at the guidelines, I was hoping to actually find an answer, but there is no answer. They say pick either, and I'm like, okay, well, thanks. That doesn't help much. So I started looking into the side effects. We know that your GLPs cause a lot of GI side effects. Your GLPs are majority injectables, majority. Now there's oral agents, but majority are injectables. If somebody has pancreatic cancer, thyroid cancer, we should avoid your GLPs. If you look at your SGLT2 inhibitors, these are the ones where you urinate out the sugar. If somebody has a history of urinary tract infections, I wouldn't use SGLT2 inhibitors. Genitourinary infections, I wouldn't use SGLT2 inhibitors. Okay? Other than that, there isn't any flashing lights saying pick GLPs versus SGLT2 inhibitors. And that's it. That's it. That's our summary. So to go back to just the high level summary, which is one of the most important things, is after metformin, what do we look at? We say, does the person have ASCVD? Do they, and you guys write this out with me because I want to make sure before we finish today, you know this. Do they have chronic kidney disease? Do they have heart failure? Or are they over 60 plus 2 risk factors, which could be high blood pressure, high cholesterol, smoking, or central obesity? Okay, now you guys tell me the answers. I'm not telling you the answers. If they have ASCVD, what do we give? Which one? Very good. You can do GLP or you can do your SGLT2. What about kidney disease? What about CKD? SGLT2? What about heart failure? SGLT2? And then what about over 60 with 2 risk factors? Very good. LPRA. Very, very good. I wanted to, very, very good. That's really good, guys. Wanted to mention one more thing before I forget. You know how I said the risk factors like high cholesterol, high blood pressure? It doesn't matter if the cholesterol or high blood pressure is controlled. If it's controlled or uncontrolled, doesn't matter. So even if the question says, oh, they're over 60 years of age, they have a history of high blood pressure, but it's controlled, doesn't matter. The fact that they have a diagnosis of hypertension, they still fall within this category. Make sense? And we did it right on time. How are you guys feeling? Does that make sense? You know, when it comes to the treatments, there's so many different, in ASCVD, GLP would be much better option. And then heart failure than SGLT2. So an ASCVD, either is okay. I tried to find some literature to pick one over the other. I read, like in a small blurb in the guideline, that GLP may have a little bit stronger ability to lower A1C, a little bit, but they don't pick one over the other. So if it's ASCVD, GLP or SGLT2 is fine. But if it's heart failure, then SGLT2 is okay. ARNT SGL should be contraindicated in less than 30. So when it comes to reduce creatinine clearance, you have to decide whether it's starting the drug brand new or continuing. Okay? Are we starting or continuing? The guidelines focus on continuing. If you're going to start brand new and their kidney function is low, we have to be careful. You know what I mean? I know it's funky. Okay, you got it? Okay, very, very good. Awesome. Any more questions, comments, concerns, confusions? Oh, thank you. You guys are awesome. You guys made it fun for me. I think the key, do you see how the key is just understanding the basic? If you understand the basic, then you can tackle anything. And a lot of it is just looking at what the patient wants, right? That was fun. Yay! I'm glad we had fun. Oh, that's awesome. I'm gonna take it back to our team. Yay! Oh my gosh, you guys made it easy. You guys picked it up so fast, which is awesome. Well, thank you, dear students, for attending. It was a lot of fun. I'm going to pass it on to Arav, one of our colleagues with SolrX, who can say a few words.
Sure. So thank you so much, Farah, for that wonderful diabetes review. I hope everyone enjoyed it as much as I did. It was great. It brought back a lot of memories for me as well. So good job. And thank you so much, guys, for participating. And, as we've said, a lot of these lectures, they are more meaningful when you engage, when you ask questions, and that's the way to learn. So good job. Now, just quickly, does anybody else have any questions on anything else? Farah, so just somebody saying, do we need to know preferred drugs in the class?
Yes, so you should know the names of the medications. So you should know what is an example of an SGLT2 versus a GLP, and we'll be covering those in detail in the class. So we'll give you the drug tables in class.
Perfect. So I guess just quickly, if at all anybody is interested, and we hope this is just a preview. There's a lot more details, as Farah mentioned, that we'd like to take up in the course itself. So our course starts on January 28th, and it goes until May 1st. There are 28 classes spanning over 14 weeks. And there'll be bi-weekly classes on Tuesdays and Thursdays from 9:30 to 2:30. And I'll just share my screen to show you. So that's what the course looks like. So the first few weeks there'll be 7 classes of management, and there will be 21 classes of therapeutics. The management portion will include calculations, and there'll also be a midterm mock for calculations and management, where you'll be judged based on the NAPRA competencies in the actual exam. And the course also gives you a final mock at the end of the 14 weeks as well. So I hope that gives you an idea of what the course would look like. All the NAPRA competencies are going to be covered, as I mentioned. A lot of the management questions, case-based questions will be discussed in class, thought processes, and very importantly, as Farah mentioned, a lot of summaries. There's an ocean of material. I mean, there's a sea of the material is quite vast out there. So Our job is to make sure you guys get proper reviews, summaries that Farah has done so well in the past. That'll really help you focus towards right towards the end in your preparation journey. Okay, so let's see. Does anybody? Okay, so the question is, Dr. Farah will be giving, so yes, absolutely. Dr. Farah will be teaching a lot of these topics, her expertise in the past in academia. So absolutely, Dr. Farah is going to be there throughout, in fact, for most of the classes as well. And especially, she's handpicking, designing all of the therapeutics for you guys based on her experience and based on the exam, quite tailor-made for you guys. So yes, she will be there for a large part of the course. Anybody else have any other questions? Yes, Denreen, great question. So yes, the spots are limited. We try and we want to give an experience where people have an opportunity to engage. So we do want to limit the size if possible, where everybody gets a chance to engage, everybody gets access to mentors in the program. There are lots of mentors in the program who are licensed pharmacists who have all given the exams. And Dr. Farah is there throughout as well as a mentor for all of you guys. So yes, they are limited. So I'd urge you guys that if you guys are considering, obviously historically speaking, that if the spots fill up, obviously on a case-by-case basis, we can see if we can accommodate you guys. So feel free to message us if the dates or something is clashing for you. Email us. Obviously, there are details on the website as well. And yes, Denreen, the course for the MCQ is online. That's correct, via Zoom. And recordings for the sessions will be shared usually on the next day or within 2 days of completion of a class. So you guys have a good chance to review all that has been taught in class. Okay, anybody else have any other questions?
I think there was a question I saw. Oh, there we go. Table for kidney dysfunction. If they ask what to initiate in the kidney dysfunction other than linagliptin, I would do your GLPs. So other than linagliptin, it's safe to initiate a GLP, any GLP. Sorry, I just scrolled up. Sorry, didn't mean to interrupt.
Okay, so yeah, Clarice, January 28th will be the beginning of the MCQ course. OSCE courses will be roughly around those by the end of the beginning of Feb as well. But keep in mind, usually we design it in such a way that people who are taking both of our components of the solrx course, then we make sure that you are allocated a seat in a week or on a day where your MCQ and OSCE course do not clash. So if certainly you guys are interested to take both, feel free to reach out to us as well. And we'll make sure that the course dates don't clash for you guys. Anybody else have any other questions? Okay, and so we know time and again we try and we put forth, as we did, this was diabetes month and we wanted to do a diabetes review. So similarly, we want you guys to engage with us, no matter what questions, preparation strategies, whatever it is, send us an email, but at the same time, do respond to our Google Forms that we create. And usually we do a poll of what next you guys would want to hear from us on, what are topics you guys want to discuss with us. So again, certainly engage when we are presenting, but also try and engage and also let your peers and colleagues know that engage with us through those forms so we get a better sense of what the masses want to discuss with us. So I think so that should be a wrap for us. It looks like everybody is done with their questions. I guess any last takers? Looks like no. So perfect. Once again, thank you, Dr. Farah, for presenting a wonderful lecture on diabetes today. And guys, more to come. And we look forward to meeting you, talking to all of you. And we look forward to having you all as colleagues very soon. So please keep engaging with us and feel free to message us, call us, email us. And thank you so much for coming today and talking to us. Farah, any last words for them?
No, we can't wait to see you soon and follow us on social media, Instagram, Facebook, Telegram. We have our lots of different groups. So we just want to support you during your journey. And you know me and the team, and that's just what we want is just to be there for you all throughout and beyond. So thank you.
Perfect. Thank you, guys. Have a great night or a good morning in whatever part you're in. So thank you so much once again, and talk to you guys and see you guys soon. Bye-bye.
Bye.